Great. It's now my privilege to introduce Dr. Mark Pomerantz. He's a physician at the Lange Center for Genitourinary Oncology at the Dana-Farber. His particular clinical interest is in prostate cancer, but he actually has the unenviable task of covering prostate, bladder, and testicular cancer for the next 30 minutes. So please give Dr. Pomerantz your attention, and thank you.
All right. Hello, everybody. There is a lot of material to cover. Again, I'm Mark Pomerantz. I'm one of the genitourinary oncology attendings at Dana-Farber. And I do specialize in prostate, bladder, and testicular cancer. My focus in research is mainly in prostate cancer. I'm going to move through these diseases fairly quickly. Please feel free to ask me questions later if anything comes up. I have no financial disclosures or conflicts to report. We'll start with prostate cancer. Prostate cancer is by far the most commonly diagnosed cancer among men in the United States. And it's right now the second leading cause of cancer death among men in the United States. There are over 31,000 patients who are expected to die this year with prostate cancer. And the mortality rates in prostate cancer may be rising, an issue that I'm going to address later. One of the unique features about prostate cancer relative to some of the other more aggressive forms of cancer is the discrepancy between the number of new cases that are diagnosed each year and the number of deaths. There is a big difference between these two numbers, and it does influence the way that we think about prostate cancer screening and treatment. Most men diagnosed with prostate cancer will die with the disease rather than from the disease. And it does call into question how aggressively we want to screen. We know that in the screening era, and as you all know, the backbone of prostate cancer screening is the PSA test. In the PSA era, we are diagnosing prostate cancers early. And in the first 30 years of the PSA era, prostate cancer-specific mortality rates per 100,000 individuals in the population was declining. And so there was some circumstantial evidence. We were diagnosing it earlier, mortality rates were going down. There was some circumstantial evidence that PSA screening was saving lives. But we knew, just like with mammography and colonoscopy, that we needed randomized controlled trials to prove to us that prostate cancer screening saves lives. And there were two giant studies launched in the 90s in the United States and in Europe. The American trial was the PLCO, and the European trial was the ERSPC, that randomized tens of thousands of patients to PSA screening or no PSA screening. The US cohort was a little bit older. The PSA cutoff for sending a patient to the urologist for biopsy was a little bit different. It was 4 in the US, 3 in Europe. But they were designed generally the same. And famously, in 2009, the Europeans reported their mortality data. They saw a slightly statistically significant mortality benefit for screening at 9 years. The p-value was 0.04, and it was estimated that they needed to perform 144 radical prostatectomies to save one life at 9 years. It was considered a little modest. The American trial was going on at the same time, and when this was published in the New England Journal, the editors decided to publish both studies simultaneously. The American study at 11 years showed no mortality benefit. The screening and no screening curves overlapped completely. And this was very compelling, and this is what made the headlines in the New York Times and in the lay press. That's something that most men were submitted to at their primary care doctor's office. PSA screening was not saving lives at median 11 years follow-up. And that has fundamentally changed, as we'll talk about briefly, screening patterns in the United States. But it's very, very important to appreciate a couple of things about these trials. First, in the American trial, there was huge contamination in the no screening arm. Over 80% of men randomized to no PSA screening actually received prostate cancer screening during follow-up for this trial. So it really wasn't a screening versus no screening study. It was really more screening versus less screening. And that was reflected in the difference in the number of diagnoses across the arms. They weren't that different. And that's because many of the men in the no screening arm were getting PSA screening. There was contamination both ways in the European trial. And so these studies, particularly the American study, was flawed. Yet the American study results were incorporated into subsequent screening recommendations, which we will talk about. A lot of us are paying close attention to a subset of the European study that was launched a little earlier in Sweden, where 20,000 men were randomized to screening versus no screening, and there seems to be less contamination in this subset. And it's been reported out a couple of times separately. With the longer follow-up and the cleaner screening versus no screening arms, we are starting to see a separation of the curves as we get to 12, 13, 14 years. And the number needed to treat at 14 years, the number of radical prostatectomies performed to save one life was down to 12. And with more recent follow-up, it was estimated that the risk of developing metastatic prostate cancer that is associated with a lot of morbidity and mortality was reduced by 30% in the screening arm versus the no screening arm. And this longer follow-up, it does seem to be important. Prostate cancer has a very long natural history from the time it's found to the time that it causes morbidity and eventually leads to death. And the longer that we follow these screening versus no screening cohorts, the wider we do expect these curves to be and the more pronounced the benefit to be. And this was modeled in an editorial last month in the New England Journal, in which the European trial was modeled out to 25 years follow-up. And even in this more flawed study, this study that's less clean than the Swedish subset, it was estimated that there would be 11 excess diagnoses, perhaps unnecessary treatments, perhaps, to save one life at 25 years. And in a 55-year-old patient, that may be an acceptable risk. Yet the recommendations don't or have not until now reflected that. There are recommendations that come down from the urologists and the medical oncologists at the American Cancer Society. And the medical oncologists have been the most aggressive in their recommendations, recommending that all men ages 50 or older with a 10-year life expectancy receive prostate cancer screening, with earlier screening for the patients at highest risk of the disease. African Americans, who among all ancestral groups have higher risk than any other we've looked at. And men with a family history of the disease who are also at higher risk. The medical oncologists are recommending more aggressive screening for these groups. But the guidelines that people pay perhaps closest attention to are from the US Preventative Services Task Force. And famously in 2012, based on the American and European randomized trials largely, they said that there is moderate or high certainty that the harms may outweigh the benefits of screening. And they responsibly cited many studies that showed that aggressive treatment for prostate cancer, when prostate cancer is found, that aggressive treatment is associated with long-term morbidity, urinary incontinence, and erectile function at rates much, much higher than conservative management. And this is what they concluded. We do think, and studies, including studies from Brigham and Women's Hospital and our urology department, have shown that since these recommendations were handed down, and since the original studies were published in the New England Journal in 2009, that rates of prostate screening have changed in the United States. They have gone down appreciably, and we're increasingly concerned that that is affecting long-term outcomes. After years and years of decline in prostate cancer-specific mortality, mortality rates from prostate cancer are stabilizing and may be starting to increase. This was an update from the American Cancer Society in 2018. And it's possible that there is an association between the decreased trends in screening and the changes in prostate cancer-specific mortality. We're going to learn more and more about this in the 2020s. And as a result, the U.S. Preventative Services Task Force has changed their recommendations. They took into consideration what many of us were saying about the flawed American study, and now recommend that for patients between ages 55 and 69, physicians should discuss screening based on the values of the patients and the doctor, which is a little vague, but it does open, but it is much more open than the recommendations from 2012. And the landscape is changing. We are hopeful that PSA screening can be informed by other considerations, other variables. And one that is on its way is imaging. And this is the Precision trial that was published in the New England Journal. The Triton trial was published this year in the New England Journal, which was also a prostate MRI study. And using the MRI, we think that we can find more accurately and more regularly the prostate cancers that need to be found, and avoid finding the low-grade prostate cancers that do not need to be found. And I'm happy to talk more about this in the Q&A. So once a prostate cancer is found, there have been and still are two main options for curing the patient: radical prostatectomy or radiation therapy, with or without hormonal therapy, which we'll touch on, and increasingly active surveillance for the low-grade prostate cancer patients. We know that prostate cancer is often harmless, and these are long-term data modeled through 15 years of follow-up. And we know that if we don't touch the patient with low-grade or even intermediate-grade prostate cancer, a fair amount of time, the prostate cancer will never catch up with them. So active surveillance has been developed to avoid the morbidity associated with curative treatment for as many patients as possible. And if we choose low-volume, low-grade patients, we know that we can safely watch them and at the very least forestall the morbidity associated with cure of prostate cancer. For the patients who do need to be cured, radical prostatectomy is still a preferred approach for many of our patients. While the higher grade patients are not cured as commonly as the intermediate or lower grade patients, radical prostatectomy does have a role, we are finding, for the more aggressive localized prostate tumors. We know that long-term local control is better in the patients that undergo a radical prostatectomy. And when a patient does undergo a radical prostatectomy, we do get to see what's really going on under the hood. We get to find out if the disease is more aggressive than we were anticipating, more locally advanced than we were anticipating, and we get a second crack at it with radiation after surgery, which has a chance to mop things up. We do not have the same opportunity in most patients who start with radiation. And for our younger patients, we do lean towards radical prostatectomy for the patients who are undergoing a curative approach. For our older patients, we are leaning more and more towards radiation. Radiation is gentler on the neighborhood in that busy neighborhood of the prostate. It's not associated with the patients don't undergo general anesthesia and don't have to recover from surgery. However, it is a little bit more of a drawn out process. For all intermediate and high risk patients, it is given along with androgen deprivation therapy, taking away the man's testosterone. This corrals the disease and also sets the cells up to die more easily from the radiation. For our intermediate risk patients, we treat them for 4 to 6 months. For our high-grade patients, we've learned that a longer course of hormonal therapy is necessary to optimize outcomes. And outcomes are statistically significantly better when we treat with long-term hormonal therapy. Again, there are considerations regarding the side effects associated with each of these. And for our younger patients who are curable, we lean towards surgery, and for our older patients, radiation, along with androgen deprivation therapy. And androgen deprivation therapy remains the backbone of our patients with advanced prostate cancer. And we are learning that even when patients become resistant to androgen deprivation therapy, they still depend on the hormonal axis. And over the years, we've developed new hormonal therapy tools to keep the pressure on the prostate cancer before we have to turn to chemotherapy. And ultimately, chemotherapy can be effective for our patients with metastatic disease. But one of the take-homes that I do want to emphasize regarding prostate cancer is prostate cancer screening recommendations are changing, and we are concerned about the consequences of the decreasing screening trends over the past 10 years. And a diagnosis of prostate cancer does not necessarily mean treatment for prostate cancer. Active surveillance is very reasonable in our low-risk patients. And one of the most feared consequences of prostate cancer screening, which is a prostate cancer diagnosis leading to the morbidity associated with cure, does not have to happen in the current era with active surveillance. And I'm going to move on to bladder cancer. Bladder cancer, while much rarer than prostate cancer, is still a leading cause of cancer death and cases, particularly among men in the United States. The male to female ratio is 3 to 1. So it is something that affects many, many patients each year in the United States. There are multiple risk factors for bladder cancer. The biggest ones are age and tobacco use. The majority, though not all, bladder cancer cases are associated with smoking. There are several occupational hazards as well that we don't see as often as we used to. Most bladder cancers are considered transitional cell carcinomas or urothelial cell carcinomas. A minority are squamous, and they're treated a little bit differently. They're not as responsive to medicines. They do require surgery whenever possible. Most patients present with hematuria and are often treated for a UTI. But if hematuria persists despite treatment, workup is indicated, ultimately a referral to urology for cystoscopy and urine cytology. The staging of bladder cancer is very, very important. And the most important distinction is whether or not the tumor has invaded the muscle or not, whether we have a T2 lesion and above, or a T2 lesion and lower. That really determines how we subsequently treat. And so any resection of the tumor must include the muscle layer so that we can evaluate T2 status. And so we generally bin bladder cancer into three groups: the non-muscle invasive, the muscle invasive, T2 and above that are local, and metastatic disease. And the approach to each bin is a little bit different. For the non-muscle invasive, taking out the tumors with a TURBT is critical. And for the higher risk non-muscle invasive patients, we treat with intravesicular medicines such as BCG, which can prolong the time to muscle invasiveness and perhaps avoid it altogether. For the lower grade patients, repeat resection is the vast majority of the time treatment enough with serial cystoscopies. For the muscle invasive patients, they need cure. And the standard traditional cure is to have the bladder removed with a cystectomy. And to optimize the cure, we now know that neoadjuvant chemotherapy with a cisplatin-based regimen, the traditional regimen is MVAC, is indicated for all patients that can tolerate it. This is a disease that tends to affect older people, so not all patients are surgical candidates, and not all surgical candidates are candidates for cisplatin-based chemotherapy, and that needs to be taken into consideration. There are ways to spare the bladder and not perform a cystectomy using a combination of radiation and chemotherapy, usually cisplatin-based chemotherapy. This can be standard, but to optimize hormonal radiation therapy, there are several considerations and multidisciplinary meetings with the radiation oncologist and medical oncologist are critical. And then I will mention for metastatic bladder cancer, the standard approach remains cisplatin-based chemotherapy, but immunotherapy is beginning to play an important role. And then I will move on from here, and we can summarize and talk nuances in the Q&A for any questions. Most testicular cancers are germ cell tumors. 95% of testicular cancers are either seminomas or non-seminomatous germ cell tumors. The other 5% are from other cell types, Sertoli cells and Leydig cells. It's a rare disease. There are only 8,000 to 9,000 cases in the United States each year, but it is the most common solid malignancy among men ages 15 to 35, and it's highly, highly curable. So a prompt discovery and treatment of this aggressive but curable disease is critical. There are a few risk factors. Family history is a risk factor, and an undescended testis at the time of birth that needs to be pulled down by the urologist does put guys at higher risk for this disease later in life. And it could be either testicle, not necessarily the one that needed to be taken down. Most often, patients just note a nodule fixed to the testicle itself, and that's how they report. Though it can be associated with some discomfort, and that's what brings the young man to the urologist. It is diagnosed with a scrotal ultrasound. The scrotal ultrasound is able to identify the tumor, and no biopsy is needed, no further workup. This is enough to declare it a testicular cancer and report for orchiectomy. Before orchiectomy, tumor markers need to be drawn, and at some point, as the disease is diagnosed, a staging CT needs to be performed. Testicular cancer drains to where it came from. The testes actually are developed in the embryo in the retroperitoneum, and that's where the disease drains. And the first place, almost always, that we see metastases are the lymph nodes of the retroperitoneum. The lungs are the second most common site of metastasis. There are multiple histologies, but broadly, we divide the germ cell tumors into seminomas and non-seminomas. The seminomas make beta-HCG, never AFP. The non-seminomas can make both. The seminomas are radiosensitive and are generally more indolent than the non-seminomas, which can be highly, highly aggressive. We generally split the germ cell tumors into the stage 1 tumors that are confined to the testis, the stage 2 that are confined to the lymph nodes, and stage 3 is everything beyond. For the stage 1, where the CT scan is unremarkable and the tumor markers have normalized, they may be elevated before surgery, but they're normal after surgery. Recurrence is unusual with seminoma. It's seen with these more aggressive non-seminomas, but still, for stage 1 disease, 20 to 40% of the time, the patient is cured. 60 to 80% of the time, the patient is cured with radical orchiectomy. So we do have the option with these patients, because chances are they're cured with orchiectomy, to just watch them with serial scans and serial tumor markers. And that's now in 2020, that is the favored approach. Even though there are adjuvant treatments that we can do, we can treat with adjuvant chemotherapy. We can take out the lymph nodes for the non-seminomas. We can treat with radiation for the seminomas to ensure a cure. But most patients in 2020 diagnosed with stage 1 disease are watched, because we know we have a safety net with these patients. We know they are highly, highly curable if they do indeed recur by using chemotherapy, which is something that's unusual about this solid tumor, how reliably curable it is with chemotherapy. Over 97% of patients are cured, even if they recur after surgery, surgical resection of the testicle. Even for our advanced patients, the patients that present with metastatic disease, even these patients are curable with chemotherapy. We split the non-seminomatous germ cell tumors up into good, intermediate, and poor prognosis. And the pure seminomas don't even have a poor prognosis group, just good and intermediate. And we use the extent of the disease and the tumor marker levels to put patients in one of these groups. And to give you an idea of how curable these can be, the good prognosis groups includes patients with lung metastases and elevated tumor markers, yet they remain highly, highly curable with good 5-year overall survival rates of well over 90%. Even the poor prognosis patients, the patients with disease that is extended to organs beyond the lungs, they do have a fairly high cure rate, given that this is a very advanced, very aggressive solid tumor. There are long-term risks associated with any of these treatments, and these patients do need to be followed closely for the rest of their lives. They are at higher risk, no matter what treatment they received, for cardiovascular events. And they are at higher risk for secondary cancers, particularly the patients that received radiation or chemotherapy as part of their treatment. Their risk for secondary cancers are higher than smokers. There are considerations that we need, that we are beginning to think about during this crisis. For prostate cancer screening, we can defer prostate cancer screening for at least 4 to 6 months for most patients. For our localized prostate cancer, the low-risk patients can definitely defer treatment. And for our active surveillance patients, we can defer our biopsies as long as PSA is stable. And PSAs can be performed near home, and televisits performed for those patients to ensure that these types of things can be deferred. For our intermediate and high-risk patients, hormonal therapy really does give us a little bit of a cushion before treatment is indicated. And we have been using hormonal therapy to forestall radiation and surgery during the pandemic. Unfortunately, for bladder and testicular cancer, we don't have quite the same cushion. And for our higher risk patients, for our higher risk bladder cancer patients, and for all testicular cancer patients, we do need to push ahead. And I will move on to our questions. So this is regarding prostate cancer. Which pairing of treatment and clinical scenario is incorrect? A prostatectomy for a 57-year-old with a Gleason 7 disease in 4 of 6 cores and a PSA of 5. Is that reasonable? What about active surveillance for a patient with a Gleason score of 6 in 1 of 12 cores and a PSA of 4.5? Let's see, 2 to 3 years of androgen deprivation therapy and radiation for a 65-year-old with 6 of 12 cores with a Gleason score of 8 and a nodule on digital rectal exam. And D, radiation alone for a 60-year-old with a Gleason score of 4+3 in 8 of 12 biopsy cores with a PSA of 8 and a small prostate cancer nodule. Which pairing is incorrect? Do I hit it? So the answer most of you got is D. This is not considered adequate treatment. With a Gleason score of 4+3 with this intermediate risk disease, we do want to treat with a course of testosterone suppression, of androgen deprivation therapy. These treatments, A through C, were all reasonable.
Thank you. Okay, great. Well, thank you so much, Mark. I know it was a lot to do within 30 minutes, so thank you. And your talk really generated so many questions. So will you be able to stay on for the Q&A session at the end?
I'll be there.
Great. So thank you for everyone who sent in all the questions for Mark. He'll be able to address them at the Q&A session. So thank you.